Hi, everybody. Welcome to today's presentation on cholesterol. I think just about everybody I know has high cholesterol, including myself. So I am very interested in today's presentation. High cholesterol has plenty of treatments, so we are very lucky to have Washington University endocrinologist, Dr. Goldberg, here today to talk to us about risk factors, prevention, and management. And I also told her I think she's probably the coolest physician I've ever met with the hair. I want to do some purple in my hair. I'm thinking about that. So without further ado, I am going to turn things over to Dr. Goldberg and let her talk to us about high cholesterol.
Thank you very much for that nice introduction. So I'm going to talk about cholesterol, what you need to know. And first of all, I have a disclosure slide. I do clinical research, all of those research contracts. And I'm involved with an organization called the National Lipid Association and do a little consulting, but not a whole lot. So let me start with some basic stuff. What's a lipid anyway? You know, I do lipids. Well, the lipid is a general term from the root lipo, meaning fat, and it refers to cholesterol and triglycerides and other types of fat in the body. So it's kind of a generic term. So cholesterol is a fatty material that's made by the body. It's found only in animals. Plants don't make cholesterol. They make related chemicals that are called plant sterols. And cholesterol is really important. Every cell in the body makes cholesterol. It's used to make the membranes that keep cells together. It makes hormones like estrogen, testosterone, cortisol, and other important hormones. It's a precursor to vitamin D. So it's a fatty, waxy substance that's not soluble in water. So it's carried in the blood by something called lipoprotein. So triglycerides are the other fat that's of concern. And this is a type of fat that's made in the intestine from what you eat and also made in the liver when it derived from fuel that gets to the liver like sugar and fats. And triglyceride is a storage form of fat. It's stored in fat cells and it's an energy source. So it gets carried around the body also in lipoproteins because pure triglycerides are not soluble in water either. They're just a fat. So what's a lipoprotein? This is what I spend all my time doing. So lipid equals fat and lipo plus protein is a lipoprotein. And so because cholesterol and triglycerides are fats and they're not soluble in water and oil and water don't mix, and the blood is mostly water, you've got to get a way to carry these fats around the body from one place to another, from where they're made in the liver or made in the intestine to other places where they're used, where the triglycerides are removed to be used as energy and the cholesterol has gotten away from the body and gotten out of the body. So lipoproteins carry cholesterol and triglycerides around the body and they come in different sizes. And so the way that the sizes were discussed initially was by putting them in a very high-speed centrifuge and then spinning them up, and they come out at different densities. So LDL, which everybody's heard about and quote the bad cholesterol, is low-density lipoprotein, and that gets into the walls of the arteries to cause blockages. The higher the LDL, the worse off people generally are. LDL cholesterol is what we get a measurement of in a lipid profile, the test we do, and that's the cholesterol that's carried around in the LDL particles. HDL is called high density lipoprotein, and this is a rather complicated heavy molecule that is mostly protein and cholesterol, and it helps remove cholesterol from the body, but it does a lot of other stuff. It's pretty complex. HDL cholesterol is the cholesterol that's carried around in HDL particles. So LDL and HDL are not found in food. They're made in the body. And so the lipid profile measures the total cholesterol, which is the sum of the HDL and the LDL and another cholesterol containing lipoprotein that mostly carries triglycerides. And that's what you get when you do your fasting lipid profile. So why do we want to lower cholesterol? So lowering LDL cholesterol decreases the risk of heart disease and stroke. So when we have high LDL, it increases the risk, and lowering LDL decreases the risk. So we want to decrease the blockages that occur in the arteries around the heart, the coronary arteries, the arteries around the brain, the carotid arteries, and the ones to the legs, that are the femoral and the iliac arteries. So if you have a big blockage and you dam up a coronary artery, you can end up with a heart attack. If you completely block one of the vessels feeding the brain, you can end up with a stroke. And to the legs, you can get peripheral vascular disease, and you can't walk then without getting pain. So heart disease is the leading cause of death in both men and women. And the risk of heart disease can be decreased by modifying risk factors. So a lot of what we talk about all the time is risk. Who is at risk? I mean, should we put everybody on medication for their cholesterol levels no matter what? We don't really think so. What we do is we evaluate how much at risk people are, and then we use that to categorize the people and decide who is going to benefit from cholesterol lowering, who is going to benefit from medicine, and other things. So I'm going to talk a little bit about risk factors. So risk factors are the things that increase the likelihood of developing a disease, and some of them can be changed, although it may be hard. So quitting smoking is a huge effect. Smoking is a tremendous risk factor for heart disease and stroke. And so quitting smoking can make a big difference. And then exercise can help. If you don't exercise, that's a risk factor. If you're very sedentary, that's a risk factor. You can treat blood pressure, cholesterol, and diabetes, both with lifestyle changes and with medications. You can't change age, and you can't change heredity. And there's social factors: poverty, poor environment, like you don't have any sidewalks to walk on, or you can't go outside, a lack of health insurance and access to health care, systemic racism. So triglycerides, why do we want to lower triglyceride levels? Well, very high triglycerides, when they're over 1,000, can cause what's called pancreatitis. The pancreas is an organ deep in the body, in the upper abdomen, and if it gets inflamed, which can happen when triglycerides are really high, you get bad stomach pain, nausea, vomiting. People need to be hospitalized. They need narcotics for the pain. They can't be fed at all. It can be life-threatening. And the goal is to get the triglycerides much lower. I'm not going to talk much about triglycerides. I'm mostly going to focus on cholesterol and LDL cholesterol. I'll talk a little bit about what helps triglycerides. A little bit of history. So that you still read things on the internet about cholesterol is not important, okay? Well, you know, my bias is that LDL is very important. I've been doing this for 39 years, and I see the effects of high LDL levels, and I see the effects of lowering LDL levels. So the importance of cholesterol has not always been accepted, but the evidence of this goes back to rabbit studies done in 1913. So we've got over 100 years worth of data. We've got data on all kinds of ways to lower cholesterol, and we're starting to get acceptance after some of the big studies in the 80s and 90s, showing that if you lowered the cholesterol level, that you decreased heart attack and stroke. And these are well-designed, randomized trials, you know, lots and lots of people, and the evidence keeps piling up. So we have diet studies. We have studies that show that changing diets can decrease the risk of heart disease. We have animal studies and experiments, and many studies in humans now with several different classes of cholesterol-lowering drugs. So we have seen from these studies that lowering LDL cholesterol decreases the risk of heart attacks and strokes. And this works in men and women with and without heart disease, and in a lot of different groups of people, and large analyses of, you know, hundreds of thousands of people have shown this benefit. So what can we do? What changes cholesterol? Well, genetics is a big factor. You can inherit very high cholesterol levels, and actually about 1 in 250 people inherit a disease called, or a disorder called, familial hypercholesterolemia, where there's LDL is about twice normal. It's high from birth, and people get early heart disease and stroke. Dietary saturated fat affects cholesterol levels. Dietary cholesterol also does, but it's a smaller effect. Weight gain can affect them. Medications of various kinds can raise cholesterol. And then certain illnesses like a low thyroid level and certain types of kidney disease can affect cholesterol levels. But about triglycerides, again, there's a lot of genetics here, but weight is a big factor, exercise is a factor, and diet is a very big factor. So calories, sugar, fat, and alcohol, all of these things get to the liver and cause the body to make more triglycerides in the liver. Diabetes is a major cause of higher triglycerides. Kidney failure causes high triglycerides, and there are a bunch of medicines, Accutane, which is for acne, oral estrogen preparations in some people, and some blood pressure medicines can also raise triglycerides. And there's actually a fairly long list. So what do we do? So one of the things we want to do is we want to decrease dietary saturated fat. And you can get up to about a 20% drop in the LDL when you do that. It depends on how bad it is to start. If you have a McDonald's diet and lots of saturated fat, you know, and you change that to healthy eating, you can get a big drop. You can decrease the cholesterol in the diet. That often goes along with decreasing saturated fat because it's carried in the same foods. Some plant materials that are in fortified margarines can help, sometimes as much as 10%. If you take psyllium a couple doses a day, that might give a little bit of a further drop. There's some effect of exercise on cholesterol and some effect of weight loss. So the idea is that we want people to eat a dietary pattern. You know, it's the overall effect of what you eat. It's not like individual superfoods. You know, some people think that since blueberries might be really helpful, that eating blueberry muffins is good. But in fact, that's probably not the case. It's really more, we want a pattern where you eat lots of vegetables. You eat some fruit, you eat whole grains. You can include low-fat dairy products, poultry, fish, legumes, beans, non-tropical vegetable oils, nuts. And then you also limit sweets, sugar-sweetened beverages, and red meats and processed meats. So where is the saturated fat coming from? Coconut oil is 90% saturated fat. And in spite of everything you have heard, coconut oil is not good for you. There are just no data showing a benefit. And if you feed people coconut oil, it raises LDL really, really well. So LDL goes up a lot. Butter is not better than margarine. Butter has about 7 or so grams of saturated fat per serving, and you can get margarines or butter blends that are down to 2 grams of saturated fat per serving. And then your processed meats, which are bad in a number of ways, are very high in saturated fat. If you see a lot of white stuff in your processed meat, like what you see in salami or that half of the bacon or what's in the sausage, that hard white stuff is saturated fat. Saturated fat is hard at room temperature, like stick butter, like that white coconut oil. Also high fat cuts of meat. So look at all that fat around the prime rib or the ribs, the ribeye. All of that is saturated fat. Egg yolks have cholesterol, but they also have a fair amount of saturated fat. And then the full fat dairy, full fat milk, cream, ice cream. So those need to be, you know, a lot of these things, it's not like you can't eat any of some of them, but you really have to watch it if you're going to have a whole eating pattern that minimizes saturated fat. Prepared foods with all the ingredients. So reading labels gets to be kind of important. So what do you substitute? So instead of the high fat dairy, do skim milk, and low and non-fat dairy, do non-fat yogurt. Margarine, tub margarines, not stick, and unsaturated vegetable oils like soybean, corn, and canola. And some of these are like the store brand. If you turn the bottle around in the store, you look at the label and it says the ingredient is soybean oil. Those have low saturated fat. In the case of soybean and corn, they have more of another type of fat called polyunsaturated fat that actually can help lower LDL and triglycerides. And then lean cuts of meat lean beef and pork, mostly from the back of the animal. If you eat pork, white meat, poultry, and fish, just not deep fried fish, because deep frying just makes fish less good for you. Whole grain breads and cereals, and most vegetables and fruits. So when you change your meat, poultry, and shellfish amounts to a reasonable amount, like 6 ounces a day, that helps decrease cholesterol. And you can eat your shrimp. If you do eat shrimp or crab or lobster, just control the amount and don't add butter. But your other, if you eat oysters, clams, scallops, those are actually low in both saturated fat and cholesterol, unless of course you make them with cream or other things. And then people probably need to cut down on the egg yolks, but you can eat egg whites, a really good source of protein. Not eating organ meats. So liver, just don't do it very often. Do your liver maybe once a month or something if you want liver. And then cutting down the dairy fats. The cholesterol is actually found in the fat in all of the high fat dairy. So when you skim off the fat, you get less cholesterol. So you also want to watch the cheese amounts as well. Now, if the LDL is still high after the improved eating and exercise, then some people are going to still need medication. They can be perfect. They can eat a very, very good diet, a pescatarian diet, just fish and vegetables, and still have a high cholesterol. So the question is, what do you want to do? Or if you have a bad heart problem, or you have other vascular disease, even a cholesterol that might be sort of in the normal range may be too high for you. So how low? Well, it looks like the longer and lower that you have the LDL, the better off you are. So in the case of the inherited high cholesterol problem called familial hypercholesterolemia, shows up at birth, I start treating those kids by about age 8 to 10. In people who don't have any vascular disease, you kind of would probably, if the LDL is below 100, that's pretty good. If they do have vascular disease, then you probably would consider treating them if the LDL is over 70. And in some high-risk people, you might even want them lower. And there are other factors that affect this, which if you have questions, I can answer. Lowering triglycerides is really dependent on lifestyle. So a little bit of weight loss can help, and watching the sugar, fat, alcohol, and calories in the diet. Exercise can help. Treating the diabetes helps if people have diabetes. So getting the blood sugar down makes a difference. And then sometimes we use medication. So sugar, there is sugar everywhere, all over the diet, all over our food supply. It's just really, one of these things is just there everywhere. And there are some forms of sugar that are kind of easy to figure out. So liquid sugar. So when you start looking at the added sugar in the diet, liquid sugar is a big thing. So these are the sugared beverages like regular soda. So a can of regular soda, 12-ounce can of regular soda has the equivalent of about 12 teaspoons of sugar. Soda's 12 ounces of juice, most juices. So juice is not good for you. Soda, things like, these sports drinks, or if you go to Starbucks and you get some of these blended frappuccinos, etc., that you get from different places. Many of them have lots and lots of sugar. So, and the other thing is alcohol. So alcohol, people will say, okay, alcohol is good for your heart, etc., etc. Drink wine, etc. If you don't drink alcohol, you should not start just because you think it's good for you. A little bit is okay in most people, but alcohol raises triglyceride levels. And some of the particles that come out of the liver, where the alcohol affects triglyceride levels, turn into LDL particles. High doses of alcohol worsen high blood pressure in some people. And then there are other bad effects. You get into large amounts of alcohol, you have damage to the liver, to the brain, and other organs. And then, the risk of accidents and homicide. The general recommendation is that men should drink no more than 2 servings per day, and women no more than 1 serving per day. And probably less than that is better, especially as people get older. And so what's a serving? Well, a serving is not a 6-pack of beer, as you might think living in St. Louis. So a serving is 5 ounces of wine, 12 ounces of beer, and 1 to 1.5 ounces of spirit. So if it's 100 proof, that's 1 ounce is a serving. That's a half an ounce of pure alcohol. So to lower triglycerides, we do diet. We watch the sugar, the cakes, the pies, the cookies, the candy, the ice cream, the juice, the soda, the Gatorade, the regular Kool-Aid, the alcohol, the calories. Many of my patients use their grandchildren as excuses for eating lots of sugar because the grandkids need it. Well, the grandkids don't really need it either. Give them fruit instead. A little bit of weight loss can help. 5% weight loss in people who are overweight can make a difference. Exercise helps. So if you exercise every day, that actually can help with the triglycerides. You can do several short sessions per day, but there's still some people who end up needing medication. So physical activity is a major risk factor. I'm actually sitting as a risk factor for everything, and certainly cardiovascular disease. And so one recommendation now is that people get up and walk around like 2 to 5 minutes every hour. My watch tells me if I've been sitting too long. And so I get up and I walk around, or I stand in my office and I dance or do something and move around. What about physical activity? Well, it does help LDL. It helps triglycerides if you do it every day. It improves blood sugar. It can help blood pressure. It can decrease the risk of heart disease. It has effects on mood and sense of well-being, and it's good for the brain. So really, you know, exercise, physical activity, moving, just moving the body is good. Makes you feel better. It helps. Any kind of moving the body. You know, walking is fine. So what about diet and exercise? So LDL cholesterol can go down in most people. Lifestyle change is additive with drug therapy. And the effect of diet can be a 30 to 20% drop in LDL cholesterol, depending on how high, what you start with. And triglycerides can go down by as much as 90% with control of calories, sugar, fat, and alcohol in the diet. So let me talk some about medications. I'm mostly going to talk about medicines that lower LDL. The medicines that lower triglycerides get to be kind of more complicated. So what do we have? First are the statins. They are the first choice. They work, they're safe. We have a ton of data. The first statin, lovastatin, which was called Mevacor, came out on the market in 1987. We have now 30 years of experience with statins. And there are 7 statins. All but one is generic, available as a generic. And in fact, number 7, pitavastatin, there's actually a mail order service that does it at about $1.25 a day. They are once a day pills. They do not need to be taken at night. They can be taken any time of day with or without food. It makes no difference. They're extremely forgiving drugs. They come in multiple doses. They have different properties. So sometimes you want to get the right fit to the person. I spend a lot of time trying to fit the statin to the person and getting people on some statin. I mean, I even have some patients on a little bit of rosuvastatin 3 times a week, and that often brings down the bad cholesterol pretty well. So the statins work by decreasing the production of cholesterol by the body, and that makes cells in the body import more cholesterol. So LDL goes down, and it goes down by anywhere from 20 to 60%, depending on how much and which one. There are many studies out there, you know, dozens of studies, and the statins decrease the risk of heart attack and stroke. These have been done all over the world, men and women, everywhere. The triglycerides go down some, but statins don't always lower the triglycerides a huge amount. And as I said, most of the statins are available now as generics. There are a few interactions, so so you can look at the different statins and pick one that doesn't interact with other meds. There are some side effects, like all drugs have side effects. I mean, I think that many of the blood pressure medicines have way more side effects than are seen in statins. sometimes some GI side effects, sometimes headaches, different things in different people. It's sometimes hard to sort out. If you look at the muscle aches that are what people tend to complain about, those occur in maybe 5 to 10% of people. And a lot of times there are underlying things that are going on, and they may or may not be related to the statin exactly. And sometimes it's related to the dose of the statin. So maybe the dose could be lowered, or maybe the statin could be changed, or the dosing timing could be changed. And so almost everybody who's had problems with a statin, could really, with enough work, can get onto some statin. And I work very hard at that. People talk about liver tests. So liver enzyme tests go up in a few percent of people, 1 to 2% in the clinical trials. Most of the time they go back down to normal, even on the same dose of the statin. And this is not a problem. Statins do not kill the liver or the kidneys. They are very, very safe. There's a slight increased risk of diabetes, which you can work on by working on the lifestyle stuff. And really, the people who get diabetes are people who are at risk of diabetes and need to work on their lifestyle anyway. So statins are number 1. So number 2 at this point is Zetia or Xenomide, which is generic. And this is a drug that's been out for 20 years. And this works by decreasing the amount of cholesterol that gets absorbed in the intestine. Cholesterol gets absorbed in the intestine either from food or actually gets reabsorbed as it comes out in the bile. So the liver delivers cholesterol to the gut, and half of that gets absorbed. So the body recycles cholesterol. Cholesterol's kind of takes a lot of work for the body to make, and so it gets recycled. So if you keep it from being absorbed, that means less cholesterol gets back to the liver, and then the liver pulls in more cholesterol, more LDL from the blood. There's not much ezetimibe in the blood. It really sort of gets kicked out of the body pretty quickly. It is not a statin. It does not have statin side effects. It's got very few side effects. It's a generic, and if you add it to a statin, you can get anywhere from 5 to 30% more drop in the LDL. So it combines with it's 2 different ways of doing things, and so you really get kind of a nice additive effect. You can use ezetimibe by itself, but typically it only lowers the LDL by about 15 to 20% when you give it by itself. Now, there's new stuff. So for a while, I do clinical trials of cholesterol medicines, and for a while it seemed like things had slowed down and there was nothing interesting happening. But about 12 years ago, people started looking at something called PCSK9. PCSK9 is a protein that affects how much cholesterol gets picked up by the liver. And people found that you could block this and it would make the liver pick up a lot more cholesterol, a lot more LDL. So these are 2 medicines called evolocumab and alirocumab, and you hear about them as Repatha and Praluent. And these are given as a subcutaneous, just under the skin injection by a pen, or usually by a pen every 2 weeks, sometimes every 4 weeks can be done. And they lower the LDL by 40 to 70%, but they're usually added on top of statins, because when you add them on top of a statin, you get an even lower LDL, and that gives a greater benefit, including decreasing heart attacks and strokes. They are expensive. They come in pen injectors, and they need to be kept in the refrigerator and then taken out, and then they're self-injected, sort of like insulin pens. And they work really well. They're pretty much, most of the time, if you want to use them, if I prescribe them, I have to do like some sort of form of prior authorization for them. And then the coverage can vary. Bempedoic acid is an even newer one. So these 2, the Praluent and Repatha, came out in 2015. They're That's when they were approved, and within a couple years, there big studies showing a benefit in terms of strokes and heart attacks came out, were published. Bempedoic acid is another one called Nexletol, and there's a combo pill with Xenomide called Nexlizet. So this has just come out in 2020, the beginning of 2020. It lowers LDL by, when you add it to a statin, it lowers LDL by 15% more. If you give it by itself, it's about 25%. And if you give it as the combo pill with ezetimibe in somebody not on a statin, you can get maybe up to 40% drop in LDL. It's limited to people who have an inherited high cholesterol, particular familial hypercholesterolemia, or vascular disease, like a history or a history of blockages in the heart or to the brain, heart attack, stroke, stents, bypass surgery, bad vascular disease in the legs. So it's limited and it's expensive, but it's a once a day pill. So it's oral. The newest, one of the newest, is something called inclisiran or Leqvio. This works differently. This is also something that blocks this protein called PCSK9. And what it is something that gets into cells and uses the cell machinery to not make this protein, the PCSK9 protein that affects LDL levels. So this is given as a once every 6 month injection after the first two. So you start out one day, there's an injection, then there's another injection at 3 months, and then another 3 months, and then every 6 months. These are done in a healthcare facility, like an infusion center, somewhere where somebody else is giving it. This is kind of like if you know about Prolia, which is used for osteoporosis. It's kind of that same kind of idea that you give it in a facility. And it pretty much lowers LDL by 50%. And the LDL just goes down by 50%. And again, this is something that's typically used on top of other medication to get the LDL lower. It can be done by itself, and you get about a 50% drop, but it's limited to people who have, again, this particular inherited high cholesterol or have some sort of vascular disease. And again, it's quite expensive at this point. So those are the ones I'm going to talk about. So just to summarize, high cholesterol levels, high LDL are a risk factor for heart disease, and lowering LDL cholesterol decreases heart disease and stroke risk. Diet, I can't emphasize enough that lifestyle is really important. So good eating and moving are very helpful, and they have multiple other benefits in addition to helping with the cholesterol. And then there are several types of medication available. Statins are still the #1 choice. In fact, when I do clinical trials, which I do of new things, you really can't do a clinical trial at this point unless in people and not have them on a statin. That's considered the standard of care. I mean, that is considered good care now. And so doing a study where you don't have people on at least some standard of care therapy is really not great. And it takes a lot of effort to prove that people can't take statins if you're doing a study in people who can't take statins. So statins are just the standard at this point. So thank you for your attention, and I'm very happy to take questions. I'll look at the chat, and I will stop sharing. There we go. All right. Let me turn on my gallery view. I don't see anything yet.
So, well, I have a question. So I have high cholesterol. The bad cholesterol is high, but also my good cholesterol is high. So the ratio is good. How does that affect treatment?
Right. So the ratio. So people have talked about ratio for a while. So a good ratio may be protective and high HDL may be protective, but the measured HDL is complicated, and so it may not be protective. And so generally we still look at the LDL. If the LDL is high, we still do something about it. So there is a question in the chat. What are the additional risk factors with age for statins? So I assume this means risk factors for use of statins, or maybe risk factors. Let me just answer both parts of it. Okay, I'll just make assumptions. So risk goes up with age. Okay, when you look at LDL is bad for the arteries. And if you talk about a lifetime accumulation of LDL, there's more and more plaque in the artery. So in fact, age is one of the biggest risk factors when you're looking at risk. And so risk goes up with age. Now, if you're over 75 and you are completely fine and you have no evidence of vascular disease, then maybe you don't need to treat the LDL. So I look at all of the factors. I look at the family history. I look at, blood pressure. In women, I look at whether they had any pregnancy complications. I look at inflammatory problems, like if they've got rheumatoid arthritis. So I look at a number of risk factors. Now, certainly as people get older, they may be frail, or they may have more problems with statins. And so sometimes what you do in older people, either with heart disease or without heart disease, you may want to use a lower dose of statin to decrease the side effects. So another question is, do coronary arteries look better after cholesterol is lowered? Yes, they do, actually. So we have studies where if you put a little ultrasound probe in the coronary arteries during a heart catheterization, you can look and see how much plaque is there. And in fact, when you get the LDL quite low, the plaque decreases in size. So you actually get a decrease in the bulging of the arteries. And we've known about this actually from various kinds of imaging studies of the heart and the coronary arteries for quite some time. People started doing these studies in the 80s. And we now have more and more data showing the lower you get the LDL, the better off you are. So my regular doctor says I don't need to treat my high cholesterol, but a heart doctor says I should. Well, there is some difference of opinion, but I would think that the cardiologist is probably going on the basis of what the current evidence-based guidelines show. And the evidence-based guidelines suggest that you look at people at risk, and if the risk is high enough, then you treat them. So what gives the best visibility into if your heart is blocked? Is there a better way than cholesterol level? So you could have a relative with a very low cholesterol and still have a blockage, right? So actually, all of these things are, you put into like an equation, not an equation per se, but you analyze the risks. So high LDL tends to cause increased risk, but there are a couple other things that I didn't talk about that people may want to know about. So one thing is another protein, another particle called lipoprotein a, which we have known about for a while, but we're now learning is definitely something that increases risk. And you can have relatively low levels of cholesterol, but high levels of this lipoprotein a, and that increases risk. And if you combine that with smoking, for example, you can get blockages, even with LDLs that are not too high. So migraines on statins. So the best way to tell if a statin is causing a problem is what you do is you stop the statin for a week or two so that it's gone. All the statins are gone from the body. Any statin is gone from the body by 2 weeks. And so if the side effects don't get better within 2 or 3 weeks after going off the statin, then probably not the statin. And then different statins have different effects. And so some people may have an issue with one statin and not with another. And, everybody's different. 10% of people taking a class of blood pressure medicine called an ACE inhibitor or lisinopril get a cough. Okay, but not everybody. Paxlovid and statins. So yeah, so there can be drug interactions with the two things that are in Paxlovid. So generally what we would do is we would hold the statin for 5 days while people are taking Paxlovid. Dietary advice for not to exceed per day for added sugar and saturated fat. So if you want a number, it's recommended that no more than 5% of calories should come from saturated fat. So say you're eating 2,000 calories a day. So 5% of that would be 100 calories. And there are 9 calories per gram of fat. So that would be around 10 grams of saturated fat per day. And so you would look at what's coming from your protein foods and your other saturated fat foods. And that's kind of the way you would go. But instead of a number, sometimes it's just better to look at the whole pattern and then take a look at individual foods that could be fixed. Sugar, probably would try to avoid as much sugar as possible. It's hard to give an actual number, and it depends on the circumstances. Brilinta and a statin. So I'd actually have to look it up. There are probably some drug interactions with Brilinta and some statins, but not all statins. Usually what I do is when I am going through a list of medications that I'm going to add a statin, I run a drug interaction program and see if there's any reported interaction. And I look at how the different other medicines are metabolized and see if there might be some interaction there. I don't know all of them off the top of my head. I can tell you a bunch of them off the top of my head, but I don't know all of them off the top of my head. Triamterene. Okay, so triamterene, not so much, but the hydrochlorothiazides. So hydrochlorothiazide can raise triglycerides and can raise cholesterol. Those are a couple of the things. It's not in everybody. It depends a lot on what the numbers are to begin with. If I have a patient with high triglycerides in the 300 to 400 range, though, sometimes you put them on certain types of beta blockers like metoprolol or atenolol. That will raise the triglycerides, or hydrochlorothiazide will raise the triglycerides. Carvedilol is a beta blocker that does not bother the cholesterol levels or the triglycerides. So sometimes you can just play around with the different medications within a group to see. Okay, I can talk about another 20 things.
Can I ask you a question?
Sure.
Zetia, using Zetia alone and the I guess it's an anti-inflammatory effect of the statins that helps with heart disease as much as the lowering of the cholesterol. Is that a truth?
Well, Zetia alone doesn't work. It's just not as effective. So people talk about other properties of statins, but actually, if you go back about 40 years and you look at some of the various experiments, LDL actually has pro-inflammatory effects. And if you lower LDL, that has a significant anti-inflammatory effect. And so part of the anti-inflammatory effects of the statins are probably due to lowering LDL at the wall of the artery. There may be other anti-inflammatory effects of statins. It's still an area of research. I don't think that's the major impact. Inflammation is part of the problem, but LDL itself, as it gets into the walls of the arteries, causes a lot of inflammation. It causes all sorts of chemicals to form and causes a lot of inflammation underneath the inner layer of the artery. So it's a really good question. And inflammation is still an area of research and controversy. Okay, I want to bring up one thing until I get the next question, and that is coronary artery calcium scoring. So one of the things that can be done to decide whether people are at risk is to do what's called a CT scan. Takes a very short amount of time, and you look at the amount of calcium that's in the coronary arteries. and you get a score. The score was developed by a guy named Dr. Agustin from Miami, and who actually has this Miami Beach diet. I disagree with him on a bunch of the diet things. But anyway, this score will tell you whether you've actually got plaque in your arteries. Now, if you have a 0 score when you're 75 and you're not an active smoker, maybe you don't have to start a statin if you're not on one, if you don't have any problems. But a calcium score that's high in a younger person suggests they're already developing a lot of plaque, and you probably want to do something about the cholesterol. Vitamin D does not help lower cholesterol. Vitamin D does a bunch of stuff, but it doesn't lower cholesterol. If you have really low vitamin D levels, you can have muscle problems. And so replacing the vitamin D, getting the vitamin D levels up, can be helpful in that circumstance.
How often should people get their blood work done and get their cholesterol tested?
So generally, once I see people in my clinic, I would look at a level and see if it's been done in a couple months. And then I usually will if I'm making changes in medication, I would like to recheck every 2 to 3 months. After that, once I get the levels down to where I want them to be, I usually just check once a year, unless there's some major change. There's some Medicare programs, some of these Advantage programs and all do not allow for cholesterol testing. And there's a big, we are worried about that. The National Lipid Association is working on some of this measurement coverage issue because you really need to know what's going on. If you put people on a medication, you want to see whether it's working and whether the levels are low enough. But once I get the levels down, I check once a year. Now, if I've got somebody who starts out with a really high LDL and I'm going to put them on multiple meds, I will be probably checking every 2 to 3 months as I'm making medication adjustments. And then when I get to where I want to be, then I'll just do once a year. Does CoQ10 impact levels? So CoQ10 is another area of controversy. So this has all come out that, statins affect a whole chain of events in making cholesterol. Statins affect an early step in making cholesterol, and there are a bunch of steps down the line that are affected. And one of the things that goes down is something called ubiquinone or CoQ10. And people thought this was important, that you needed to replace CoQ10. And actually, that turns out not to be the case, because what gets measured in the blood doesn't really relate to what's going on in the muscles or in the mitochondria or in the cells. And several studies have been done looking at giving people CoQ10 and seeing if it makes a difference to statin side effects or how their muscles work on statins, and it doesn't make any difference at all. Some people think and find that taking CoQ10 helps them take a statin. And if the CoQ10 helps them take a statin, I am fine with that, whether or not they're data or not. But if you take over-the-counter stuff, you don't really know what's in it, whether it's safe. They're not evaluated by the FDA. So supplements are not evaluated by the FDA. And usually the FDA only gets involved in the supplement if something bad happens. When I was a resident in the late 70s, or between 77 and 80, there was a paper in the New England Journal about a bad inflammatory problem that was caused by a contaminant in a supplement called tryptophan. And people were using it for sleep, and the contaminated line of tryptophan caused a severe inflammatory problem that made people quite sick. There have been other supplements that have caused very bad things as well. So when you're dealing with supplements, it's like, let the buyer beware, because you can go to some databases that will tell you they've evaluated supplements and look to see whether they're okay and whether they contain what they're supposed to contain. But the supplement industry is billions and billions of dollars, completely unregulated. talking in the low humidity always makes me cough.
We have a few final minutes if anybody else has any other questions.
Let me bring up another thing. Since I decided to leave plenty of time for your questions and not cover everything and everything. Let me bring up lipoprotein little a. So as I said, this is another particle. It's kind of an LDL-like particle with another piece of protein attached. It is inherited as a separate level from LDL or triglycerides. So it's a separate type of inheritance. And about 20% of the population has actually levels that are above normal. And the higher those levels are, the greater the risk of heart attack and stroke. That it actually is a particle that promotes blockages and contributes to actually clots in the arteries. It can also cause calcium to deposit in the aortic valve and cause what's called aortic stenosis. And so probably everybody should have this level checked once. If it's normal, you don't have to worry about it ever again, because it doesn't change with almost everything. There are some new drugs in development that do affect it, but very little makes it change. And so I just want to bring it to your attention, and you can start asking about it. The other thing that I want to bring up, which relates probably to your kids and your grandkids, is that we would like to see everybody have at least one cholesterol level by the age of 9 to 11, preferably before they start puberty, to find people who have inherited high cholesterol and start working on their lifestyle. So we recommend between 9 and 11. This is the American Academy of Pediatrics, between 9 and 11, and again, 17 to 20. And then if there's no problem, you could check every 5 years or so, or if there are major changes in health or weight. But, I hate to see somebody coming into the hospital at age 45 with a very high cholesterol level that was never checked before, and they have a heart attack. Because if we lower in my families with the inherited high cholesterol, if we lower the cholesterol level from a relatively young age, they don't get heart attacks and strokes. So maybe their grandparents had heart disease in their 40s and 50s, but their parents who've been on a statin for 20 years have not had a heart attack or stroke. And I'm wanting the kids to not even develop the plaque, the blockages. So we want to start early and treat early. So I think the other thing is asking me what I was talking about before. It's called lipoprotein A, or the way it tends to be written is lipoprotein and then parentheses small case a, lipoprotein little a. You'll be hearing more about it. Are there any open cholesterol studies in St. Louis? Well, thank you for asking. This is what I do. I am doing a couple studies that I'm still recruiting for. I'm recruiting a study that's inclisiran study, which is an outcomes trial in people who are actually well treated for their cholesterol, have had a heart attack or stroke, or who have known peripheral vascular disease, but their cholesterol is still above about 120. And they get randomized they get assigned to either this injectable every 6 months or placebo. And we don't know what they're taking, and people are not supposed to know what they're taking. We don't want to know what the cholesterol levels are. That's one study. I'm doing some triglyceride studies for people with triglycerides above 500 and a history of pancreatitis. I am doing some studies in kids. 6 to 17 is one study. It's a pill study for 8 weeks. And I'm doing a inclisiran study, this injection every 6 months that lowers LDL by 50% for kids who are 12 to 17. And they have to have this inherited high cholesterol problem called familial hypercholesterolemia. And then I am also doing another study in people with familial hypercholesterolemia who are on a high dose of statin and maybe something else. and their LDL cholesterol levels are still over 70. And that's a new medication that's 1 pill a day. It's a year-long randomized placebo-controlled study as well. It's called Brooklyn. And actually, if you go, we have flyers out for it. So if you go to the endocrine division website, it's www.endocrine.medicine.wustel. You can see some of the studies that our division does. I'm not sure whether all of my studies are on there, but we're working on it. This is a new thing.
Does VLDL, the very low density lipoprotein, is that more significant than the total lipoprotein? And does it have anything to do with lipoprotein A?
No, VLDL is separate from lipoprotein A. VLDL is a triglyceride particle made in the liver that carries, it's about 80% triglycerides, and it basically is a triglyceride particle that goes from the liver and around the body to deliver triglycerides, which are used for energy storage, for energy. It is not related to Lp(a). Lp(a) only relates to a particle like LDL. VLDL goes up when you give the liver lots of sugar, fat, when you give it alcohol, or a lot of calories. VLDL levels go up. It is definitely not a good particle to have a lot of. And so when you have high VLDL, you have high triglycerides. The question is whether lowering triglycerides is good enough to decrease risk. And that's still a big question right now. There's still a lot of research on triglycerides. I am a professor of medicine at Washington University School of Medicine. I work at the main Washington University School of Medicine, Barnes-Jewish Hospital campus.
Well, I am aware of the time, and that hour went fast. And Dr. Goldberg, you are a wealth of information. It is such a privilege that the Merowitz Center has these top doctors who speak for us. And we so appreciate you taking the time today to educate us. Today's program has been recorded, so I know there was a lot of information, and we will have the recording on our website so that you can review everything that Dr. Goldberg discussed today. And I have to say, I'm going to think twice before I order a popcorn at the movie theater that's been cooked in coconut oil. After this talk, you've made me rethink some of my actions. Thank you again, everybody, and have a wonderful day.
Thank you very much for having me. Bye.
Wonderful discussion. Thank you very much.
Thank you.
Bye-bye.
Thank you.
Thank you. Terrific.